All these webinars are available on YouTube. I realize that
Yes.
you're streaming live.
Yes, it is available.
Okay. So I think it would be nice to also share the who's the one who's hosting it on YouTube.
Ma'am, I will
Same name, Happy Learning.
Happy
Ankur.
Learning, you search, you'll get it.
Oh,
Or connect.
that's nice.
Okay. So we are live now.
Okay.
हेलो डॉक्टर नीलम
गुड इवनिंग सर, कैसे हो? आपको मुझे
आप
देखने
सुनाओ।
का टाइम मिल गया।
So I'm starting the webinar. So very good evening to all respected faculty members and delegates who are present over here. I am Nilesh Darji from Corona Remedies. Welcomes you all in this 184th edition of Happy Learning Masterclass webinar series in association with Patinda, Faridkot, Jalandhar, Kotakpura, Ludhiana and Patiala. The theme for today's webinar is mixed bag. And the convener for today's webinar is Dr. Asha Jain ma'am. Let me introduce madam. Madam has very vast 34 years of experience in OB/GYN field. Currently, madam is director SMSA Hospital Raipur, medical director CPRS, elected member of Chhattisgarh Medical Counseling, and madam has Foxy recognized ultrasound and colposcopy training centers. Madam's field of interest are saving the uterus, fetal medicine, OB/GYN, ultrasound, critical care, preventive oncology, and colposcopy. And madam is also ISCCP colposcopy trainer. So I welcome Dr. Asha Jain ma'am. And as per the traditional course, we will start our webinar with digital lamp lighting session. Thank you so much, all respected delegates and faculty members, for your patience. Now I hand over the session to Dr. Asha Jain, ma'am. So over to you, madam.
Thank you, Nilesh. Namaskar, all respected faculty and the delegates who are listening in. To start the program, I request the director of this program, Dr. MC Patel sir, to give the formal welcome address. As you all know, this is the 183rd edition and it's been going on and on and on for so much time. Consistency, perseverance is the name Dr. MC Patel sir. And we all know that he's going for Foxy president. Election will be in August 2024. So over to you, sir. Namaskar.
Thank you, Asha, for kind words. It gives me immense pleasure to welcome you all to 184th episode of Happy Learning Masterclass web series. And today's joining society, Bathinda, Faridkot, Jalandhar, Ludhiana, Kotkapura, and Patiala. I welcome Dr. Iqbal Singh sir. He has kindly consented to be chief guest to bless the webinar. Of course, he is always with us in any of our academic activity, and his mere presence is enough to inspire us to do any academic activity. Welcome, sir, and thank you for sparing time to bless us. I also welcome Dr. Sushma Chawla, madam, from Jalandhar. She has also kindly consented to be guest of honor to bless the webinar. She is also always with me as far as any of my academic activity is concerned. Welcome, madam. I also welcome Dr. Saroj Agarwal, madam, from Ludhiana. She has also kindly consented to be guest of honor to bless the webinar. Welcome, madam. I also welcome today's learned speaker, Dr. Sunita Goyal, madam, from Ludhiana. She is going to discuss very important topic for today's webinar, early life development. What is the role of gynecologist? And this is some newer subject, or which may call it Hatke. And let us see how she is going to discuss and how she is going to justify the title. So welcome, she is a competent person to deal with. So welcome, Dr. Sunita Goyal, madam. I also welcome three learned chairperson who are going to chair this very interesting session. Dr. Ruchi Bhargav, madam, Dr. Manjit Singh ji from Batinda, Dr. Amita Sharma from Jalandhar. I also welcome all the learned panelists who are going to participate in reverse panel. They will be asking questions, and being a moderator, I will be answering. And we have selected for today's discussion MTP Act and its amendment, what gynecology should know. Because after this amendment of MTP Act, there are so many dilemmas in so many of our Foxian friends. So to clarify the doubts, we have kept this topic for discussion. So I welcome all the panelists, Dr. Monica Gupta madam from Batinda, Dr. Jagjit Singh ji from Faridkot, Dr. Surjit Kaur madam from Jalandhar, Dr. Sukriti Sharma madam from Jalandhar, Dr. Nisi Garg madam from Kotkapura, Dr. Madhu Goyal from Kotkapura, Dr. Gitanjali Kaur from Ludhiana, Dr. Gini Gupta madam from Ludhiana, Dr. Sarita Agarwal madam from Patiala, Dr. Lajja Goyal madam from Batinda, Dr. Venus Bansal from Ludhiana, Dr. Suprit Virk from Jalandhar, Dr. Tapasya Dar madam from Ludhiana, and Dr. Bhavana Sachdeva from Ludhiana. I also welcome Asha Jain, who is convener not for this webinar only, but in this series since long. I welcome Dr. Asha. I also welcome two learned coordinator, Dr. Neelam Sodhi and Dr. Rekha Rajendra Kumar. Neelam has always helped me in any of my academic activity. And for today's webinar, not only for designing this webinar, but to execute this webinar, she is with me. So welcome and thanks, Dr. Neelam. I also welcome Dr. Rekha Rajendra Kumar, one more coordinator, and she is in this series since long, and all the president and secretary of joining society, that is Batinda, Faridkot, Jalandhar, Ludhiana, Patiala, and Kotkapura, and all the delegates who have joined this webinar. In era of COVID-19, I started this series with three friends, and now even after Corona is over, then also this series is continue on demand of Foxian friends. And now we have more than 7,000 plus member as far as this Happy Learning family is concerned. And we usually discuss focus topic, and to say hello to our Foxian friends, to discuss focus topic, and to exchange our views about the subject is the motto of this series. So thanking you all and welcoming you all again. Thank you very much.
Thank you, sir. Thanks a lot for those words. Dr. Neelam Sodhi ma'am is the convener for this program. She is here. Madam is a senior gynecologist. Madam, I request you, please say a few words.
Thank you, Dr. Asha Jain, and very much thanks to Dr. MC Patel. તમે મારા senior છો અને guide છો અને જ્યારે મને જરૂર પડે છે તમે છો ત્યાં. So it's a big.
I am always there.
I know, sir. And for us all, the medico-legal field is a field which is full of minds. So we need to tread very carefully, and that is where you are always there to hold our hand. Wishing you all the very best for this journey of presidentialship that you have applied for. And Yeah, we are all there with you on the journey. Coming to the topic for today, the early life development, the obstetrician's role. I was actually reading this topic and I realized that although antenatal education, antenatal care, and antenatal education is my passion, there is so much about the first 1,000 days of life that I didn't really know about. So when Sir asked what we could discuss upon, then we decided on this topic. And in fact, Foxy has also started showing interest in this topic. Now, why the obstetrician and why are we talking about the first 1,000 days of life? Because life begins on the day of conception. So the first theoretically 280, but when you count the 1,000 and it begins from conception to end of the second year of life. So the first 270 days arbitrarily are in the lap of the obstetrician. They are our responsibility. And in fact, actually, the care that we need to give begins much before pregnancy begins, and that is in the preconception period. So when I started reading about this, I realized that WHO and UNICEF had come out with a fascinating nurturing care framework, and this is a very detailed topic, so I won't touch it there, but it includes nutrition, good health, and it also includes safety and security and something called responsive caregiving. Now, if we as obstetricians realize that life starts with us, then I think we will all feel the big importance of this subject plus the burden of it on our shoulders, that the baby that comes already comes with 25% of its brain development. The myelination of the neurons happens in the last few weeks of pregnancy. That is why a preterm baby cannot handle the stresses of the world outside. Its brain gets affected. So the brain development is one of the reasons. Second thing is the theory that long-term non-communicable diseases, the start of it comes from in utero. So if a good nutrition is given, the mother is protected from stress and toxic stress and violence. She has good exercise. She is relaxed. She is comfortable. And we protect her from the usual risks of hypertension or diabetes or anemia of pregnancy. She's more likely to produce a healthy baby. That healthy baby is going to give rise to a healthy generation ahead. So with that, I would say that we welcome Dr. Sunita Goel to handle this all-important topic.
Thank you,
Thank you.
Dr. Neelam.
Thank you, Neelam.
Thank you, sir.
Thank you, Dr. Patel and Dr. Neelam, for giving me this opportunity to share this interesting topic with you, to speak on this interesting topic. What I'm going to talk about is today is just the...
Ma'am, the scientific will start later.
Okay, sorry.
Little
sorry.
later,
It's
little
the
later.
welcome address, ma'am.
Okay.
And we could not introduce Neelam, ma'am, so I would like to do that.
Okay, sorry.
If
Not practice was the president of Ludhiana Society. She is the director of Ashirvad, the North India Cerebral Palsy Association, an NGO for children and adults with developmental disabilities. And she is a social entrepreneur, founder of healthy snacks brand Nourish. Ma'am, I'm gluten intolerant. I would really love to try something that you would make.
Definitely, definitely.
So, welcome, ma'am. I'm really sorry that we could not introduce.
No, please, please. It's fine. It's fine.
We
Please.
have Dr. Rekha Rajendra Kumar, the other convener. She is the president-elect of Kasoga. She'll be president-elect for another 18 days and then she'll take over as president of Bangalore Obstetric Gynec Society. She has many awards and felicitations, and she's been with this program for a long time. Next, I would like Dr. Rekha ma'am to introduce our chief guest, Dr. Iqbal Singh Ahuja.
Thank you, Asha madam. I hope I'm quite audible.
Yes.
We have shared the platform with sir in previous Happy Learning webinars also. but it is again my proud opportunity to introduce Sir. Sir is a very, very senior person, Director of Iqbal Nursing Home and Hospital, Ludhiana. He is the man who brought IVF technology to the entire North India. What one else needs other than this big feather on his cap? Sir has a very big biodata, very enriched biodata with lot of accolades. He has more than half a century of dedicated service to our field. He's contributed a lot, an alumni of CMC Ludhiana. Sir has trained himself in IVF from State University College of Vienna, and he's the founder secretary of IMS Ludhiana chapter, and now Sir is the chairperson of the same IMS, has received Dronacharya Award and lots of accolades to Sir. Thank you so much for your mere presence itself. We are very much happy and proud to have you here, Sir, and to sharing this space, the platform with you. Thank you so much. We are eager to listen from you so that we become wiser. Thank you so much, Sir. Can we listen from you?
Thank you very much.
Yeah.
Thank you.
Yeah. Please speak on, Sir.
Thank you, Dr. Patel, who's a volcano of knowledge, volcano of experience, volcano of energy. I think more adjectives I add will be less. He's a very hardworking person, and thank you very much for giving me a chance to meet this intelligentsia. And Dr. Asha, thank you. Dr. Neelam Sodhi and Dr. Rekha as coordinators. It's a good job. You will be doing very nicely. Dr. Sushma, evergreen. Dr. Suraj, who is an all-rounder. And Dr. Sunita, who is a learned speaker. And plus the panels of the other persons. And then I can see the young person like Dr. Nishi and Dr. Tapasya, who are very young and they are doing very good in the job. I can't mention all the names because I will be taking time, but I appreciate everybody. What I feel is why they select me as a chief guest. I didn't know why Dr. M.C. Patel always thinks of me. Then I thought about myself. When I saw biodata of everybody here, I thought my biodata is very small. And so chief guest is a person who knows less, can speak more without knowledge. And I think these qualities I have. So when I see my biodata. So that's why thank you, Dr. Patel. At least people with less knowledge get an honor also sometimes. Now experience, what I feel is, what I advise everybody is never hide your experience. When I started, when I was a teacher, so I taught all the students. And when I came in private practice also, then I also taught everybody. And then somebody questioned me, why you are teaching everybody such a nicely, because they will be your competitors. I said, no, you are wrong. If by my teaching, if they save one life somewhere in the remote village, I'll be getting a credit, not they. So one must not hide, one must teach whatever you know. And second thing is mistakes. We all commit mistakes during surgery, during teaching, everything during our lifetime in the experience of medical. I feel we should never hide. We should tell the others so that they don't commit the same mistakes which you are committing. I think this is the best thing we can do is never hide. Tell others that we committed a mistake here. Please be careful. You don't commit a mistake there. I think that is the thing. I can't take more time because everybody has a share over here. So I would like to thank you, Dr. Patel. So whenever you need a person with less knowledge, I will always be ready. Thank you very much.
Thank you. Thank you. You are so humble. And of course, you are always with us to inspire us for our academic activities. Thank you, sir, for sparing time.
Thank you, sir. Thank you, Iqbal, sir. So now we proceed with the inaugural ceremony. The next guest of honor is Dr. Sushma Chawla, ma'am. She was kind enough to share a lot of her social activities with me. She does dancing, she does a lot of camps, She's a gynecologist and obstetrician, laparoscopist, hysteroscopist, colposcopist, and IVF expert. There's hardly a hat that she hasn't worn. She's an honorary professor and dean of Dr. Don ICMCH, runs the Chawla Nursing Home and Maternity Hospital, Link Road, Jalandhar, Punjab. She's president of Narchi Jalandhar branch. She has very many accolades and she has been awarded by North India Gynec Forum for Oration, honored by IAG Punjab chapter in September 22, IMA Achiever Award, IMA President Award, Lifetime Achievement Award 2016, though there is still a lot of life left, but she has received the Lifetime Achievement Award and she's organized many workshops, CMEs and webinars. So welcome, ma'am. We are honored to have you here and would love to listen to your words.
First of all, I thank Dr. Patel for inviting me as a guest of honor. And it's a privilege to meet all of you in such a good platform. एक बात तो बहुत अच्छी है डॉक्टर पटेल, इसी बहाने से कुछ पढ़ाई हो जाती है, आगे पीछे कोई बुक्स नहीं भी खुलती. So you cannot cheer a session or you cannot be in such a good audience without reading it. So thank you very much for revising everything what I used to read previously. And now what I feel, we are more than 35,000 gynecologists, obstetricians in the FOGSI, and many things are preventable. If we just permeate and infiltrate in schools and colleges, the pre-marital counseling, the pre-conception counseling and prevention and knowledge about the sex education, I think many things can be prevented. I usually tell all school going, college going before, the knowledge for the health is so important. So as far as the first trimester gynecologist, what an obstetrician should know, many things I think we can teach even when the outgoing student in the college. They have the chapters for the nutrition, which we as doctors, we don't have. And so many things we can teach them about the premarital counseling. So I think this can really avoid many complications. And again, thank you very much for telling about what are the amendments. There are so many queries because this 2024 has brought so many new things for which there are so many queries. So thank you very much. I think there's so many doctors to discuss about it, and I will also learn a lot. Thank you very much for calling.
Thank you. Thank you, madam, for sparing time. You are always with us. We are happy. Thank you, madam.
Rekha ma'am, over to you.
Yeah, thank you, Dr. Asha, again. Thank you for giving me to introduce Dr. Saroj Agarwal, madam, another guest of honor. Madam is a very senior obstetrician gynecologist, president of Indian Medical Association of Ludhiana, honorary secretary and vice president of IMA in 2018, Ludhiana, president of Ludhiana Society of Obstetrician Gynecologists for a continuous 4-year period, speaker, chairperson in AICOG All India conferences regularly, attended many international conferences. Madam has very good hobbies, very healthy hobbies, nurtures yoga, meditation, and she is spiritually rich. She has the hobby of reciting Bhagavad Gita, and that's a very great thing, madam. Thank you so much for decorating our platform. We would like to hear from you. We are eager to hear from you, Dr. Saroj, madam.
Hello. Yeah.
Yes.
Good evening, everyone. Yeah.
Bit of
Dr. MC
not being
Patel
clear.
people are here.
Yeah.
And my colleagues are there from Ludhiana and all other places. So it is an honor and privilege for me to be invited on this forum. And these happy learning classes, Dr. MC Patel has really started some good thing. And I think everybody is happily involved in these lectures. All the Foxians are really listening to him always because he's a great teacher, a mentor, a guide for so many people. And today, the topics selected are really very nice. Early embryonic life is really important. And as Dr. Neelam said, the preconceptional care, that is a very, very important aspect. And along with that, I would really like to say that we have really been feeding the people lots of folic acid. And actually, if you give it in excess, even the simple folic acid can be harmful because so much of it goes unmetabolized, and it will release those unmetabolized folates which are going to be harmful. So these days, some people have really started adding choline, etc., in that, which is a good thing to do. And so I'm really waiting to listen to this early embryonic life by our own Dr. Sunita Goyal from Ludhiana. And then Dr. MC Patel is going to talk about MTP Act and amendments. And of course, everybody gets caught somewhere there is a dilemma. I have really saved his slides from the previous lectures for reference. So I know we are again going to have certain questions which Dr. MC Patel is going to do justice to them. And it is always a pleasing experience to hear from Dr. MC Patel. And thank you, sir, for involving me in this lecture. And I really congratulate you on this happy learning classes. And we really look forward to see you as the president of FOGSI.
Thank you. Thank you.
Yeah. Thank you so much.
Yeah.
Thank you.
Thank you for sparing time to bless us. You are always with us. Thank you, madam.
Yeah. Thank you.
Thank you so much. Sir, may we start?
Oh, yes. Yes, we can.
So we are almost on time, and I thank all the dignitaries for blessing us on this dais. Now we would start the academic session, and I would request Dr. Rekha, you can please introduce the chairpersons, and the first chairperson will introduce the topic, the second will introduce the speaker, and the third will sum up the case. So over to you, Dr. Rekha.
Yeah, thank you, Dr. Asha. I am very happy and honored to have three chairpersons here, Dr. Ruchi Bhargava, Dr. Manjit Singh sir, and Dr. Amrita Sharma. First of all, let me introduce Madam Dr. Ruchi Bhargava. Madam is MBBS from Calcutta Medical College, MD from Amritsar Medical College, Government Medical College for Amritsar, senior resident in GMCH, the same college. Madam is the director of Bhargava Advanced Gynec Surgery Cancer Center in Jalandhar, and she's been working for more than 2 decades there. She has her field of interest in high-risk pregnancy with a special focus on safe mother and healthy child. She's conducted a lot of women awareness camps. Thank you, madam. We are happy to invite you here. Dr. Manjit Singh Sidhu. Thank you. Dr. Manjit Singh Sidhu, sir, is another chairperson. Sir is the director of Preet Hospital from Bathinda, president of Bathinda OBG Society, special interest in advanced vaginal as well as endoscopic surgeries, member of important reputed societies. Welcome, sir, Dr. Manjit, to this platform. We are happy to have you as a chairperson. Please chair the session. The third chairperson, Dr. Amita Sharma, madam. Madam is the obstetrician gynecologist, eminent academician and social worker. She is the director of Central Hospital and Santan Test Tube Baby Center. Madam has decorated many posts, like she was the joint secretary of IMA Jalandhar, ex-president of FOGSI Jalandhar Society, and life member of important reputed societies. Thank you, Amita madam, for being with us and chairing the session. I hand over the platform to all the three chairpersons to introduce the speaker, topic, and take the proceedings forward. Thank you. Hello, over to chairpersons. Sunita Goyal, madam.
Should I introduce the topic?
Yeah, any of the three chairpersons, please introduce the topic, the chairperson, and the last chairperson will conclude. Thank you.
Good evening, and thank you, Dr. MC Patel, for having us here. You are actually a capsule of energy, and good luck on your presidential election post, and I'm sure you're going to be a winner. Our topic for today is early life development, the obstetrician's role. We have always known obstetrics as just the the antenatal period and then hand it over to the pediatrician. But now, as we know that the concept of communicable diseases, it is beginning in the womb. So that's where we as obstetricians have a very important role to play. And obstetrics could also be expanded to address the interrelated areas of a parent's prenatal impact on a child's brain development and their own psychosocial needs during a time of immense change and neuroplasticity. Obstetrics' new role is to make resources about newborn screening available to patients during pregnancy. Integrating education about newborn screening into prenatal care allows parents to be prepared for having their child undergo screening once the neonatal screening. So I would love to hear Dr. Sunita Goel. She's such a lovely orator. Somebody please introduce Dr. Sunita.
I think I would love to introduce Dr. Sunita. May I do it? Dr. Asha?
Yes, ma'am.
Hello.
Sure, ma'am.
Okay. And thank you at the outset. Thank you, Dr. MC Patel, for having me on this lovely platform. And Dr. Asha, of course, helping us and coordinating everything. So introducing Dr. Sunita Goel. She's Senior Consultant, Cloud9 Hospital, Ludhiana, and former Professor and Head of Department of Christian Medical College and Hospital, Ludhiana. She is a Fellow of Indian College of Obstetricians and Gynecologists. And of course, she has many accolades to her credit, with a total clinical and academic experience of 35 years. Her main areas of interest are high-risk pregnancy, reproductive endocrinology, and operative laparoscopy. She has been a regional faculty for conducting certificate courses in gestational diabetes mellitus, and she's having more than 25 publications in national and international journals. So we welcome you on this wonderful platform, Dr. Sunita. So please, you are invited to share your knowledge with all of us. Over to Dr. Sunita.
Thank you, Dr. Amita. Thank you, Dr. Patel, Dr. Neelam, and team for giving me this opportunity to talk about this very interesting topic. In a short span of 20 minutes, I will be just touching the, tip of iceberg, I would say, because this is very, very vast. There are lots and lots of things which need to be covered and looked after by us. But I will be just touching, and I may be missing out on many. So what I thought was important, I will be covering them. So what is our role as obstetrician in early life development of an individual? In 2010, UNICEF gave the concept of first 1,000 days of life.
Dr. Sunita, your screen cannot, at least I cannot see. Can the others see?
I have started sharing.
Yeah, but
it's not moving.
It's not visible.
It's not visible?
Yeah.
So what do I do? Somebody has
Double
stop
click.
and
Double
reshare.
click to enter.
Ma'am, keep your PPT open on the screen. Don't
on the screen.
downside,
Okay,
don't minimize it. Maximize it, keep it open, and then reshare.
Okay, so I go back. I had not opened it.
Yeah, so
एक्सक्यूज मी सुनीता मैम,
यस,
आप मुझे व्हाट्सएप कर सकती हैं क्या? मुझे व्हाट्सएप कर दीजिए, मैं रन कर दूंगी आपकी स्लाइड्स।
मेरे पास व्हाट्सएप पे नहीं है, मेरे पास उसमें ही है।
आप डॉक्टर सुनीता, सबसे पहले आप शेयर करना बंद करिए। देयर इज अ स्टॉप शेयर आइकन अप देयर। फर्स्ट यू डू दैट।
ओके, स्टॉप शेयर।
Yeah.
Open your PPT.
Now stop share. Now
Okay.
open the PPT on your laptop. Keep it full screen. Like just open it,
Do
maximize
not
it.
keep it full screen. Do not
Make-
keep it full screen.
No. First she has to maximize that, and after that press the share button.
Share
Then you're
screen.
going to get it.
Ma'am, if she maximizes it, she will never get it. it has to be in the normal view, जिसमें साइड में छोटा स्लाइड दिखता है।
वही
Highlights
कह
आना।
रही हूँ, वही कह रही हूँ, पर स्क्रीन में नीचे नीचे नहीं आना चाहिए, खुला होना चाहिए। दैट्स व्हाट आई मेंट, कि खुला होना चाहिए। डॉक्टर सुनीता?
हाँ, okay, just a minute.
Yeah.
The small eyelets on the side, she needs that.
Okay, now
When you click on share screen, are you able to see your PPT? Click on share screen, then you will get a window which opens, and there you will be able to see the PPT that is open.
yeah, I can see.
Now click on that.
Share screen.
Yes. You can see your PPT, click on the PPT or double click on it, and then there is share.
Now you can see?
Yes, now we can
Yes.
see. Now you can go to slideshow.
Okay, okay. Actually, I'm doing it after long, so I forgot that it has to be opened first. So,
That's okay.
okay.
Go to
now it-
slideshow, ma'am. First, go to slideshow.
Okay. So,
Dr.
now
Sunita,
everybody
we
can
can
see the
still
slide.
not, yeah, but we cannot see the full screen. So go to slideshow on top.
Slideshow, I'm not.
हाँ है आपके पीपीटी के ऊपर, हमें दिख रहा है, ऊपर है बिल्कुल। या नीचे आइकन है स्लाइड शो का, आपको नीचे जो 365% जहां लिखा है मैम, उसके बिल्कुल साथ एक नीचे, आपकी स्क्रीन के नीचे राइट साइड,
मेरी स्क्रीन के नीचे राइट साइड पे कुछ नहीं आ रहा,
जहां आपने पीपीटी शेयर करी है,
वो आ ही नहीं रहा।
आ रहा है, हमें दिख रहा है। ऊपर जो बार है जहां पे सारे वो दिए हुए हैं, this
Home,
bar on
insert,
top, you can see
design,
slideshow
yeah.
there.
Home,
Slideshow.
insert, design, animation, slideshow.
Slideshow.
Your screen sharing is paused आ रहा है।
नहीं कुछ, अच्छा, we can see it.
मैम एक बार escape
Resume
button दबा
slideshow.
दीजिए।
Yeah, resume slideshow.
अभी भी
Resume
नहीं आ रहा,
slideshow.
अभी भी नहीं आ
Click
रहा।
on, click on resume slideshow.
उसमें your screen sharing आ गया।
मैम आपका कर्सर जहां पे है, उसको सबसे ऊपर, जो पीपीटी वाली जो विंडो है, उसके सबसे ऊपर वाले
Yes, madam,
हिस्से
you
में
click
देखिए।
it. When you आपका
नहीं
कर्सर
तो आप
जहाँ पे
ऐसे ही
था,
चलाने दीजिए, कोई बात नहीं, यू कैन।
I know, that is fine. ये भी अच्छा दिख रहा है।
हाँ, आप ऐसे ही चलने दीजिए मैम, कोई बात नहीं, यू जस्ट गो ऑन। यस यस यस,
yes,
राइट
yes.
राइट, दैट्स द वन। यस, जस्ट क्लिक इट।
अब
Click
मेरा
that.
वो मेरी
Yes.
अपनी स्क्रीन छोटी होगी। ओके, इज इट फुल नाउ?
No, no.
Not
मैं
yet.
वहीं पे कर रही हूँ, आई एम क्लिकिंग देयर ओनली एवरी टाइम, आई डोंट नो व्हाई इट इज नॉट बिकमिंग फुल।
All right, never mind, you just continue as it
Continue.
is. Not to worry, just continue.
Okay, so the UNICEF gave this concept of first 1000 days of life, which start from the time of conception, includes the intrauterine time of 270 days, plus the first 2 years of life. So that makes total 1000 days. So what is the importance of these 1000 days is that this is considered a critical period in which the foundations for the optimum health, growth, and neurodevelopment across lifespan are established. The nutrition and environmental factors in this time have a lifelong effect on child's overall health. If there are medical and public health interventions, they are taken on in these days, they will have a higher rates of success as compared to these interventions outside of this time period. So that's the importance of this time period. And 1/3 of this time period is the time period when the baby is in utero and the mother is under the obstetrician care. So it has been found that children who had healthy nutrition during these first 1000 days, they are 10 times more likely to overcome the most life-threatening child diseases. They complete 4.6 more grades at school. They go on to earn 21% more in wages as adults, and they are more likely as adults to have healthier families. So
Madam,
that
are
is,
you moving the slides?
yes, they're not moving.
No, we are in the first screen only, second screen rather. It looks you have gone to the fifth slide, but here on the big screen, it is only the second slide that's there.
I don't know what's happening.
Ma'am, up second, click on the slide number 3 on the left side of your screen. Don't do anywhere else, just keep clicking down there. Left side pe jo icons hai, small ones. No, not there, not there.
Actually something is coming.
Resume slideshow kar lijiye.
Resume slideshow.
Yes, now probably you're going
Second
for...
it has come, second.
No, it's empty.
Disappeared.
The screen is blank.
Is it showing?
No.
No, madam.
No slide.
Rupees 200 received on PhonePe.
Now we can see your screen. Where at the bottom, ma'am, at the very bottom, go on to, yes, just increase this for the moment because you were on, yes, slide it to the right. Yes, increase that. No, that's too big. That's too big. A little less, go on to 65%, go on to less. Yeah. Now come to the left side and you can see the number of your slide there, 3.
Yes. Acha, click on these.
Us pe click karo ab, then your slide will move. Yeah.
Yes, it's moving now. Yes.
Yeah.
It's moving. Okay.
Now go on to the next one. Yes. 4.
Okay.
Yeah. Yeah.
So this is what I said, the children who get the right nutrition during the first 1000 day do well in every aspect of life. They can fight diseases, they can study better, they can earn better, and they can have healthier families. So what happens to the brain development in the first 2 years of life plus the intrauterine? At the time of the birth, the baby's brain weighs just 350 grams. But by the time the baby is 2-year-old, the brain weighs 1.2 kg. And adult brain weighs about 1.4 kg. So 80% of the brain's development takes place within these 1000 days. So what all happens in the brain in these first 1000 days? There is neuronal proliferation, that is cell numbers increase. There is growth and differentiation, complexity, myelination, and synaptogenesis. So ideal time to provide the nutrition to ensure the normal development, and it is also the time for a greatest brain vulnerability to any nutritional deficit. So in view of all this, the obstetrician's role becomes very important to provide good care to the pregnant woman and contribute to the foundations of optimum health, growth, and neurodevelopment across the lifestyle. So now the recent concept of intrauterine fetal programming is there, which is known as Barker's hypothesis. This postulates that a number of organ structures and their functions, they undergo programming during the embryonic period and the fetal life. So this structural and functional formation determines the physiological and metabolic responses which are carried on to the adulthood. So if there is a stimulus at this time or insult during the intrauterine period, this leads to developmental adaptations in the fetus, which ultimately lead to permanent structural, physiological, and metabolic changes, which manifest in the form of cardiovascular, metabolic, and endocrine disease in later life, adult life. So what are these changes? I was trying to say if now it has started working, but it doesn't seem to be working. So there are three main forms of programming that can occur due to changes in the maternal environment. These are changes in the development that leads to greater disease risk, what I just talked about, genetic changes which alter the disease risk, and epigenetic changes. Epigenetic changes are changes which alter the disease risk of not only the child, but also that of next generation. Like, for example, after a famine in Spain, it was seen that women who were pregnant at the time of famine and they did not get enough nutrition, their children were smaller than normal size, but even their grandchildren were smaller, even in spite of the fact that the nutritional deficiencies were met in the adult life for those children. But the further next generation also became small in size because of the epigenetic effects. So these changes in the maternal environment, they can be due to nutritional alteration, hormonal fluctuations, exposures to toxins, and psychological stress and psychopathology. So I'll be discussing this one by one. So even ICMR has given that during the first 2 years and pregnancy, a stress has to be given on the nutrition of the mother, and then first 6 months breastfeeding, then complementary feeding from 6 months onwards, and family food from the 9th month onwards. So importance of nutrition in the pregnancy is very, very important. So how this nutrition affects the fetus? When the fetus is developing in the womb, it gets the impression that when the baby goes out in the world, it is going to get this type of nutritional status, whatever is the mother's nutritional status. If it is under also, it will get the impression that when it goes out, it will get the same type of nutrition. If it is over also, it gets adapted to that type of nutritional status. So development is modulated to create the best chances of survival. If there is both the excessive or inadequate nutrition, that can provoke maladaptive responses in the fetus, which manifests in the form of postnatal diseases. So that is why these things have such profound effect on the fetus adult life that it can even outweigh lifestyle factors. So nowadays we talk about non-communicable diseases and we say that most of them are related to the lifestyle factors. But this maladaptive response, which has occurred in utero, that even outweighs the lifestyle factors in creating the non-communicable diseases. So we have lots in hand to guide the mother regarding the nutrition. Both overnutrition and the undernutrition is bad for the baby. So BMI prior to pregnancy and weight gain in pregnancy, these two things are linked to high BP in adulthood. Why this happens is due to high levels of fetal leptin. So assess the nutritional status of the mother, weight and BMI, preconceptional if possible, if not at the first visit. Set her target weight gain in pregnancy. So we have a chart for, depending on the basic BMI, how much weight she should gain. Accordingly, set a target for her and she should gain weight accordingly only, so that the baby has lesser leptin level and less risk of high BP in adult life. In preeclampsia, there is inadequately developed and poorly functioning placenta. So the nutritional demands of the fetus are not met. So the fetus in adult life has cardiovascular conditions and metabolic conditions. Regarding the nutrients for growth of brain, all nutrients are required, including protein, polyunsaturated fatty acid, iron, zinc, copper, iodine, choline, folate, vitamin A, B6, and B12. These are especially critical. And iron supplementation during these key periods of peak iron need, they have proven to be an effective deterrent of later neurodevelopmental impairment. So nutritional counseling and supplements from time to time need to be taken care of. Next, we come to the hormones. A delicate balance of hormones is required during pregnancy so that there is proper fetal programming, and these significantly influence the fetal outcome. So we all know about thyroid hormone. It plays an important role during the early development of the fetus brain. Mothers who are suffering from thyroid-related issues, they can trigger the structural and functional changes in the fetal brain. So assess the thyroid status of preferably every mother so that any thyroid abnormalities can be taken care of. Cortisol, and that's the main hormone. Cortisol is the most well-studied hormone that can have prenatal programming effect. So normally cortisol is required for the development of the fetus, but excess cortisol exposure has deleterious effect on the fetal growth, on the postnatal functioning of hypothalamic pituitary adrenal axis, and the brain structure or connectivity, that is specifically portion is amygdala. So during pregnancy, cortisol concentration in the mother are 10 times higher than cortisol concentration in the fetus. How this gradient is maintained is by the placenta, which forms a structural and enzymatic barrier to cortisol. During the first 2 trimesters, the fetal cortisol is totally going from the mother. But during the 3rd trimester, the fetal adrenal gland begins to endogenously produce cortisol and becomes responsible for most intrauterine cortisol. So why I'm talking about cortisol is now I'm going to talk about the antenatal corticosteroids. So most studies of the children which are exposed to antenatal corticosteroids before 34 weeks of gestation, they have not reported any adverse effect on growth, blood pressure, lung function, psychosexual, motor, cognitive, neurodevelopment, and ophthalmological outcome. So it is proven beyond doubt that less than 34 weeks of gestation, corticosteroids are very, very good. But they should be, but it has been seen that many children, many mothers who are given steroids, they don't deliver within 1 week, after which the effect of steroids is gone. So for proper effect of the benefit of the steroids, they should be only given when you know that the mother is going to deliver in next 1 week. Now, the long-term data is coming up. So they are saying that animal studies are showing that antenatal corticosteroids, they promote the terminal differentiation of fetal organs in lieu of cell proliferation. So these changes, they lead to chronic diseases such as diabetes, hypertension, heart failure, and psychiatric disorders in the later life. So also, so how these steroids, they affect the baby's brain is, the human brain grows by 35%, cortical volume by 50%, and 25% of cerebellar development, it occurs between 34 weeks of gestation and term. And there is a surge in endogenous cortisol near term. So when you are giving normally this brain is protected from this high level of cortisol by an enzyme which doesn't let it affect on the brain. But when you're giving the steroids from outside, this enzyme is not able to protect the brain from effect of high level of the steroids. So the high level of steroids which we are giving exogenously, they go and affect on the brain, and they are associated with increased risk of neurocognitive disorders. So there's a large meta-analysis of studies from 2000 to 2021, over 21 years, more than 1.25 million children have been assessed. Those who were exposed to the steroids in utero, children who were extremely preterm birth, there they had better neurodevelopmental outcome. Children with late preterm birth, that is between 34 to 36 plus 6, they had increased risk of investigation for neurocognitive disorder. And children who were full term, they had increased risk of mental or behavioral disorder, hazard ratio of 1.47, which is very high, and proven or suspected neurocognitive disorder, which was ratio of 1.16. So the neurodevelopment outcome may be poor in a patient, in a babies who were exposed to steroids in utero at term. So a subsequent population-based study in Finland, this is a recent study in 2022, which reported possible long-term psychological, developmental and neurosensory harms in steroids-exposed children born at term. So steroids should be only given if the patient is likely to deliver in next 7 days, and the steroids at term should be avoided definitely. And of course, rescue steroids are beyond doubt that they are not to be given. They cause decrease growth of the baby. Another thing which has not been really looked at in details, and though the recommendations are there, what are the long-term cognitive outcome of early term and late preterm births? Children, so this is a systematic review where they studied the children who were born at different gestations, and they said the babies who are born at full term, 39 to 41 weeks, they have highest cognitive outcome as compared to those born at early term, that is 37 to 38. So nowadays what happens, most of the time the patients also come and the relatives also say that deliver our baby at 36 weeks, 37 weeks, because nurseries are so good, babies survive, there is no problem. But definitely those children who are delivered later at full term, that is 39 to 41 weeks, they have better cognitive outcome as compared to the babies who are delivered at early term. So this must be kept in mind when you're discussing the timing of delivery with the relatives, so that the delivery can be carried out at the full term rather than at the early term and have a better neurocognitive outcome of the baby. So this was a study which was conducted in China. They followed the brain morphometry with the gestational age at the time of birth. So they wanted to see, is there an association of gestational age at birth with the structural brain morphometry? So it's about 33,000 children, and they found that there was better gyrification and better cortical surface area of the brain in children who were born later in the full term rather than early term. So gestational duration may be important for long-term neurodevelopment and should be considered a continuum of development throughout the pregnancy. So we should not deliver patients in a hurry, thinking that, okay, now it is term, we can afford to deliver the patient. This is another study in which they found that late preterm birth elevated the risk of neurodevelopmental delay of gross motor, fine motor and adaptability, but the early term births, that is 37 to 38 plus 6, was associated with developmental delay of fine motor within the 6 months. So delayed delivery at least till 38 weeks unless strong medical indications are there. So never deliver a baby at 37 weeks saying term without any strong medical indication. So as obstetrician, we should take care of this part, that we don't deliver the baby in the early term. We all know about the effect of alcohol, tobacco. I won't go into detail. They also contribute to fetal programming, especially by alteration in HPA axis. In the alcohol, it leads to fetal alcohol spectrum disorder. And tobacco also leads to a lot of complications, preterm birth, growth restrictions. This is a well-known fact. So prenatal counseling or when patient presents to us at the first visit, ask about history from all the people, all the ladies nowadays, because this is becoming very common, both smoking and alcohol, and tell them to avoid it completely. Drugs, phytogenic and teratogenic drugs, risk of certain drugs we know very well. And now they're saying even the antihypertensive drugs, they may be associated with low birth weight, childhood depression, delayed neurocognitive development, increased incidence of childhood asthma, neonatal seizures, hematological disorders. So judicious use of antihypertensive drugs should be done. Next, we come to the mental status of the mother, psychopathology. Mental state of the mother during pregnancy affects the fetus in the uterus, predominantly via hormones and genetics. So mother's prenatal anxiety, depression, stress, it can lead to altered outcome for the baby. Look at this picture. We can see that in the normal woman, the development of the neurons are like this. There are many connections. When the stress is there and the stress becomes toxic, so the prefrontal cortex and the hippocampus, the connections are very few, neurons are damaged. So at the first visit, assess the mental status of the mother, alleviate her anxiety by positive counseling. So nowadays, even previous one abortion becomes such a big issue for the mother second time. She's very, very stressed. So we have to mentally counsel her and relieve her anxiety. Positive counseling should be done so that the proper neurodevelopmental outcomes are there. Next, we come to a very important topic, that is the microbiota. The development of human gut microbiota probably starts before the birth. So maternal and gestational factors and environmental exposures during pregnancy, they affect the healthy development and composition of fetal, neonatal, and infant gut microbiota, and thus affect the offspring's health issue. So the natural development of the gut microbiota is disturbed by cesarean section, formula feeding, and antibiotic therapy, especially in the labor and immediate neonatal period. So this leads to dysbiosis. Dysbiosis is associated with increased risk of allergies. So the delivery mode is an important factor driving the alteration in gut microbiota. Several studies have shown that alteration of gut microbiota induced by cesarean section can influence the activity of intestinal epithelial cells and development of immune system. So some autoimmune diseases and metabolic diseases may be related to this dysbiosis in infants caused by cesarean section. So prefer vaginal delivery. So now we should motivate our patients. We should prepare them during the antenatal period for vaginal delivery, and the good counseling can reduce the incidence of cesarean section on maternal request. So prefer vaginal delivery. It will lead to a healthy immune system and healthy metabolic system of the baby. Impact of antibiotic therapy, again, it changes the intestinal microbiota. It is a long-lasting effect, and there is increased risk of developing some pathologies in the later life. So there should be proper antibiotic rational use should be there. So these are certain conditions which can change the gut microbiota: cesarean section, overweight and obesity, antibiotic therapy, allergies, and celiac disease. So the type of the bacteria, the diversity of the bacteria, all that changes, which have long bearing effect on the adult life. So to sum up, ideally, we should do a preconceptual checkup and counseling. If it is not possible, at the first antenatal visit, assess the nutritional status, set a target weight gain in pregnancy, take history of alcohol, smoking, and drugs, and tell the mother to avoid them, assess her thyroid status, assess her mental status, alleviate her anxiety about pregnancy by positive counseling, and nutritional counseling from time to time, and nutritional supplements. Antibiotics, if absolutely essential, especially in the perinatal period. Steroids only if patient is likely to deliver in next 7 days. Prefer vaginal delivery. Delay delivery at least till 38 weeks unless there is a strong medical indication. So many things we need can wait. The child cannot. Now is the time his bones are formed, his mind is developed. To him, we cannot say tomorrow. His name is today. Thank you for a very patient hearing.
Thank you, Dr. Sunita, for a comprehensive profiling of the entire topic. You have covered everything so nicely and comprehensively. All these concepts are quite recent, and for those who have learned done their PGs some time back, let's say 5-10 years back, they have not been used to such concepts. So it is nice that all those people can also learn and relearn these things, which new developments are coming. And as you said, it is extremely important to take care of the nutrition of the mother and the lifestyle changes that are required. That should also be done so that the outcome is perfect. So,
Nita madam, please stop sharing.
So thank you, Dr. Sunita, for such a nice lecture. Thank you.
Thank you.
Can I just take half a minute?
Yes.
Yes, sure.
Sunita madam, please stop sharing.
I'm trying to.
Certain take-home points. 1, maternal nutrition is so very important to prevent fetal organ insult. Second important point, we are not to give antenatal steroids right and left. Today, almost all IVF patients at around 32 weeks, they are given antenatal steroids, even though the delivery is not being anticipated in the next 7 days. So we have to learn when to give antenatal steroids. Third, cognitive outcome is best between 39 to 41 weeks. So sometimes patients come, ये मेरा birthday है तो उसी दिन cesarean कर दो या मेरे घर में function है. So we should not be falling into all this trap. We should do what is best for the patient. And in late term, there are more sulci and gyri formations. So sometimes the scan report says the size of the baby's head is coming big. So I tell the patient, बड़ा intelligent हो रहा है, sulci and gyri बड़े हैं, तो आप रुको अभी, wait for it, the right time for it to go into labor. Thank you, Sunita ma'am. It was indeed such a eventful learning.
राम मंदिर निर्माण टाइम बहुत ही सिजेरियन का प्रेशर था.
Can I take a half a minute also?
Yes.
So, sir, what is the consensus? So, if we are doing an elective cesarean at 38 weeks, so should we do, first of all, should we do an elective cesarean at 38 weeks or should we program it to 39? And if we are doing it at 39 or 38, should we give steroids before doing a cesarean?
Steroids.
Ma'am, previously they were saying that before any elective cesarean, you should give steroids because even at term, they have seen.
Dr. Sunita in the Ludhiana OBGYN Society, she is the most informed on steroids. I've so often referred to her exhaustive knowledge on that. And I think this recent paper, which Dr. Sunita is talking about and which has been shared, and ma'am, it would be nice if you could share a link of that also. Then that paper actually clearly explains that there is no role of steroids. I'll let Dr. Sunita say the most, but neurodevelopmental outcomes have been found to be worse after giving steroids wrongly. So this blind following of steroids, which was just a gap of 2 or 3 years that we did. Before that, we never used to give steroids even after 36, 37 weeks. So we started that after those guidelines and recommendations. But that paper that has come recently clearly shows that this should not be done. Dr. Sunita, over to you.
See, up till 34 weeks, definitely. Even 34 to 36 plus 6, they say you can discuss with the parents. The chances of respiratory distress syndrome are very, very low. And you have to, I don't remember the exact number, you have to at least treat maybe 50 babies or so with the mother with steroids to prevent one RDS. So you can discuss with the relatives because I feel that the effect of probably the side effect, which long-term we cannot see at present, is, much more scary. And unless there is a very strong indication, we should not go for preterm labor, for preterm delivery. And you should be sure when you are giving steroid that the patient is going to deliver within the next 7 days. Till 37 weeks, you discuss with the relatives, 34 to 36 plus 6. After 37, definitely no. And the timing, actually speaking, for an elective cesarean should be at 39 weeks. But what our practical experience is that most of the mothers, they go into labor at 38 to 39 weeks, like a breech may come in second stage primary breech, or, a previous cesarean where vaginal delivery cannot be done. She may come with some scar dehiscence. So that is why 38 plus you can plan, but never definitely before 38 weeks. So nowadays, many babies are being delivered even at 36 weeks because most of them, they do survive. But that's what is not important. Important is the long-term outcome of these babies, which we don't see because those babies never come back to us. They go to the, see, even the early term and the late term difference is in the fine motor development. We won't know that the baby's fine motor development is delayed. So why delay such things? By our intervention, which can be, which can be delayed for, the delivery can be delayed for some time in these cases. So we are in a hurry to deliver and cause problems in the baby. So very strict medical indications should be followed, and definitely term no steroids. That's now proven.
Yeah.
You're right,
In one of the cases, I was defending our gynecologist friend, and a baby delivered at 37 weeks or so. An allegation on part of patient and a relative was why steroid was not given. And this was allegation in that very case. So when I was defending that gynecologist, I went through literature, and in literature it was shown from 24 to 34 weeks were the recommendation. And after that, one very good line was written. If you give steroid after 34 weeks, it has no added advantage. This word was exactly, it is not added advantage. So if you have not given steroid after 34 weeks of pregnancy, in court of law also it is accepted. Because in that very case, on my argument, court was convinced and case was decided in favor of gynecologists.
Okay,
even if in that very case, steroid was not given. There was not much problem also as far as outcome of baby is concerned. But for any other reason, they had filed a case, and one of the allegation was this, why steroid was not given.
Sir, totally agree with you, sir, and Dr. Sunita, what you've said. I would request both of you to please try to share the links to these articles so that we can widely circulate it in our fraternity and we stop doing things. Dr. Sunita, you rightly said, such babies are not going to come back to obstetricians, but they come back to us in the disability sector, in the NGOs, where we are increasingly seeing cognitive delays and behavioral issues. Autism is on the rise, and then they say the mother is responsible, but the environmental influences are responsible. So many things, ADHD, just behaviors altered totally. The child becomes hyperactive and so many other things. So these tiny things where the child cannot be included into the mainstream society, into schools, because of these small differences, somewhere perhaps they are not coming on our data, and that is why we do not see an increased incidence related to what is happening in the delivery front. But there is no doubt about it. We are trying to save smaller babies, saying that we have neonatal setups. So it's okay to bring a baby out. But like Dr. Sunita said, think of this. You do not want to be responsible for a bad neurodevelopmental outcome later on that the baby has. And like my pediatric friend says, sometimes it's just better to let a baby go than to give it a bad quality of life. At 13 weeks, we all counsel about Down syndrome. We are up to it that we have to get the NT scan done. We have to get the biochemistry done. But how many of us actually think that preterm deliveries are actually creating more harm than trying to identify that 1 in 800 to 900 babies born Down syndrome baby who does and can have a good quality of life also. So I think, Dr. Patel, this has been a great talk. Thank you so much for allowing us to have this conversation on the first 1000 days of life. And Dr. Sunita Goyal, you so aptly brought it all together. With full confidence in you to do full justice to this topic. Thank you so much.
Thank you.
Ma'am, please give consent to the repetitive single dose which is given.
See, I don't believe in giving that. I have never given. Very rarely.
Placenta previa comes at 29 weeks. You give 2 doses. Then after that,
No, why? Why you want to give?
okay.
I will not give. Placenta previa comes, I don't give. But their first episodes are always very small. Unless I know that this patient is likely to deliver, I will never give. She comes with spotting, I will not give. I'll wait for the next episode to become little heavier. Very rarely she will come with such a heavy episode that she doesn't give you time. उससे पहले हुए होंगे. So I don't know. मैं तो बहुत ज़्यादा restricted हूँ for my if I have 2 minutes, I'll tell you recently one patient of mine who started having spotting, discharge, blood stain discharge. And I was on leave. My colleague thought she was in preterm labor, gave her steroids at 34 weeks, but the patient still hasn't delivered. So unless you are sure the patient is going to deliver, don't give. I don't give. I had told my resident, don't give. Next day, she visited a consultant that other consultant gave. I'm very, very careful. I don't give. I'm very much, I like steroids. I have given to so many people who have delivered preterm. But there are certain indications when you will give. So placenta previa doesn't mean give. There are certain placenta previa, they go to the term also and they don't bleed. So placenta previa doesn't mean that you will give steroid. So if she bleeds sufficient. I think the next episode may be heavy. Soon it's a complete placenta previa covering the os I will give. But not on spotting or not just on the report of placenta previa.
And no repetitive doses.
Thank you.
No repetitive doses.
Thanks a lot. We still have a panel to go. We have another panel and we have only 45 minutes left. I'm really sorry I have to interrupt. But we really
yes, ma'am. Thank you for giving ample time.
Thank you, ma'am. Thanks a lot. So, Patel sir, may we start the panel?
Yes, we can.
Because actually we have to end on time. Today is Ramakrishna Dev's Jayanti, so I brought him first. May he shower blessings on all of us. Now we will start the MTP Act. Dr. MC Patel sir is the expert in the line of fire and I'm the moderator or coordinator. It is a pleasure to introduce MC Patel sir officially. He's a consultant obstetrician, gynecologist, and medico-legal counselor. He was the VP FOXI 2018, Organizing Secretary AICOG 2017. He was the chairperson Ethics and Medico-Legal Committee FOXI 2011 to 13, and he has continued being an medico-legal advisor to all FOXians ever since. It's been 11 years since he stopped being the chairperson. He's still continuing with the same job. He's the honorary secretary, SOGO, organizing chairperson, MMCon, honorary member, National Inspection and Monitoring Committee, Government of India, has done a lot of work. More than all the CV, what I would like to say is that he is one person who is there for every FOXian, every time. He says, keep my card under your pillow and sleep peacefully. And we all do that. And one more thing that I would like to tell is his consistency. For the last 21 years, he's been going to the Northeast and providing health services to those who cannot have those services for a week every year for 21 years. So as I said before, consistency is Dr. MC Patel, sir. So welcome, sir. And I've been introduced. These are our panelists whom I will introduce one by one. And before we start the panel proper, here is a small vote appeal from MC Patel, sir.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving FOXI for years together on this auspicious day, with folded hands and down head, I seek your guidance blessings and support to endorse my candidature for the post of FOXI President year 2026, election year 2024. Consistently working for FOXI and trying to visit even a smaller societies and to assist our common FOXian friends in any given situation, I have tried to serve FOXi. I assure to serve FOXi in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
Thank you. Thank you so much. Now we start the questions on MTP Act. So before we start the panel formally, sir, I would like to ask you, what was the need of the Act? And why did this Act come? Was it necessary? And what was the indication?
Actually, this MTP Act came into existence in 1971, and before that, any abortion services were considered a criminal offense. Even today, under Indian Penal Code 1860, to terminate pregnancy is a crime. But after this MTP Act came, it has become little safer one for registered medical practitioners who are performing termination of pregnancy in accordance with MTP Act 1971. And if you go with statistic, then almost 22 million unsafe abortion all over world per year, and out of those, 7 million abortion happens in India, and out of those 50% considered to be unsafe. And as far as maternal mortality part is concerned, abortion services or unsafe abortion shares the 8% of that maternal mortality part. And that is why government thought there should be done something to check criminal abortion or unsafe abortion. So Santilal Shah committee was formed, and Santilal Shah committee gave his report in 1966 that there should be some act, there should be some guideline how abortion services can be given to the patient. And with this guideline, this act came into enactment in 1971. And good part, as far as Santilal Shah committee is concerned, 50% members were doctors and other 50% members were influenced by doctors. And I would like to mention that in that very committee, one of the representatives from FOXi was also there. So MTP Act is doctor friendly. But just I mentioned prior, not to end up into any kind of litigation under Indian Penal Code. It is very much required under Section 3 of MTP Act that notwithstanding anything contained in Indian Penal Code or any law time being in force, registered medical practitioner will not held guilty if termination of pregnancy he has done in accordance with provision of MTP Act 1971. So that is why we should know MTP Act 1971, which are the indication, who can perform MTP, where MTP can be performed. And if we practice that way, then we are out of purview of IPC, section 312 to 316, which are having very stringent punishment. So if we have not terminated pregnancy in accordance with MTP Act, then it could be very troublesome to face in court of law. That is why this MTP Act was enacted, to have a safe abortion services and to protect registered medical practitioner who practices as per a standard guideline in MTP Act.
Thank you, sir. Thank you. Now we will proceed with our panelists. We have Dr. Monica Gupta first. She is the secretary of Bathinda Society, and with all my urging did not share her hobby. She said, I don't have time. She just spends time with her kids. So over to you, Dr. Monica. I can see you. You have to unmute yourself.
Good evening, everyone. Thank you, Dr. Patel, sir, for including me in this panel discussion. And thank you, Dr. Asha, ma'am, for organizing this webinar so well. Sir, my question to you is, what are the important provisions of the Act? And was there any punishment included in the Act?
Yes. So as far as MTP Act is concerned, as far as these important provisions are concerned, so in this Act, just I mentioned prior also in brief, where MTP can be done, who can do MTP, and it should be kept confidential as far as any record related to MTP of that very patient should be kept very confidential, and registered medical practitioner should be protected. As far as punishment part is concerned, if there is a breach of any provision of MTP Act, then there is a provision of punishment from, as far as imprisonment is concerned, from 2 to 7 years. And as far as fine is concerned, related to some inaccuracy in record, then fine of ₹1,000 is the provision under MTP Act.
Thank you. Thank you, sir. Now we have Dr. Jagjit Singh, sir. He is Honorary Secretary, Faridkot Obstetric Gynec Society, Master Trainer for Government of India sponsored programs, and he loves dancing. See.
Wow.
So over to you, sir.
Thank you, Asha ma'am and MC Patel sir. Thank you for this wonderful opportunity where I can see whole Punjab together, and we are together today also, and will be together in voting you, and looking forward for your election to be your president in 2026. Sir. Our sincere effort will be there. And coming on to this important topic, as you were rightly saying during this introduction of this topic, that the main purpose of this act was to for decreasing the unsafe abortion. So I'll be interested in asking that how effective was it, the initial act, in the purpose of decreasing unsafe abortion, and if it was going smoothly, how many time it was amended, and for what purpose, why it was amended?
So as far as initial act, purpose was, just I mentioned prior also, to have a safe abortion services.
Yes.
Because before that, when these abortion services were not legal, then people used to go to quacks or unauthorized person or untrained person, and they ended into very bad position, or in a very with morbidity or even mortality in few of the cases. So not to have this, and to have a safe abortion services, and in government hospital it is free, and all the information related to that very patient should be kept confidential, was the motto of this very act. And it has served a purpose, because then after, death related to abortion services or morbidity related to abortion services has decreased a lot. And as far as amendment part is concerned, first amendment came into in 2003. So in that very amendment, powers were given to district level committee. As far as registration of center is concerned, previously we had to apply to the state government, but with this amendment in 2003, now we have to apply to district level committee only. And of that very district level committee, CDMO, in different state, name should be different one, but Chief District Medical Officer is appropriate authority as far as MTP services are concerned, and one has to apply to that authority in that respective district only. So this amendment came in 2003, and as far as many amendment came in 2021 about failure of contraception, about opinion, about confidentiality. So there are so many amendments came in 2021, and we will discuss each one by one as we proceed with this panel. So thank you, Jagit Raji.
Thank you.
You are always with me.
Thank you, sir. Thank
Yes, next.
Next, sir, we have Surjit Kaur ma'am. She likes to read. She is the president of Jalandhar Obstetric Gynec Society. So, madam is present here. Ma'am, over to you, please. Please unmute
Good evening.
yourself. Yes, ma'am. Welcome.
I'm audible? Yes.
Yes, yes, you are audible, madam.
Good evening, Dr. Patel and
Yes.
Dr. Asha. Thank you for giving us this opportunity. And this is a very important topic which we are discussing today. There are many queries so many times. So my question is, what is the latest amendment in this act, or how does it benefit the woman and the doctors?
So as far as latest amendment which came in 2021 is concerned, one good amendment is failure of contraception. Failure of contraception is the indication for termination of pregnancy, but previously it was available to married woman and to her spouse only. But now with this amendment, word married woman is replaced by any woman and word her spouse is replaced by her partner. So now this indication is available to any woman, means irrespective of her marital status, it is available. And not to her spouse only, but to her partner also it is available. So failure of contraception is a good amendment as far as this amendment part is concerned. Second part, previously up to 20 weeks of pregnancy, we were allowed to go for termination of pregnancy. Up to 12 weeks, opinion of one registered medical practitioner was required. And after 12 weeks and before 20 weeks, opinion of 2 registered medical practitioners were required. But with this amendment, up to 20 weeks of pregnancy, one can opine to terminate pregnancy. So only one opinion of registered medical practitioner is required. If it is more than 20 weeks, previously it was not allowed, but with this amendment, now termination of pregnancy is allowed beyond 20 weeks and less than 24 weeks with opinion of 2 registered medical practitioners. There are certain indications given for that, but we will discuss little later on. After 24 weeks of pregnancy, previously it was not allowed, but with this amendment, with opinion of medical board, pregnancy can be terminated even after 24 weeks of pregnancy also at any given gestational age. But for that, there should be indication that is fetal congenital anomaly which are incompatible with life of fetus. So as far as this indication part is concerned, opinion part is concerned, is there. One more amendment came, that is confidentiality. So previously, of course, it was there, but with this amendment, if there is a breach in confidentiality of patient, then there is a provision of imprisonment for 1 year and or fine of some rupees. So now this amendment is little difficult one. As far as benefit to the women is concerned, just I mentioned about failure of contraception. And one good part, when opinion is asked from medical board is under obligation to opine within 3 days. Once application is lodged before medical board has to opine within 3 days. And once opinion comes that pregnancy can be terminated, then that very pregnancy should be terminated within 5 days. So this is very good amendment in favor of patient. Because previously what happened when pregnancy was more than 24 weeks, one had to rush to Honorable High Court seeking writ petition for permission of termination of pregnancy. High Court were referring cases to medical board, but there was no time limit given. So opinion was delayed. In one of the cases which happened, and it was published in newspaper Hindu, that this opinion was asked at the gestational age of 24 weeks, and when opinion came, pregnancy was 36 weeks. So not to end up into this type of situation, in this amendment, medical board is under obligation to opine within 3 days. So once it is referred to medical board, either by patient or either by honorable court, then they will have to opine within 3 days. So this is good amendment in favor of a patient. As far as in favor of doctor is concerned, just I mentioned prior also, MTP Act is doctor friendly. So if we practice MTP services in accordance with provision of MTP Act, then we are not at all in purview of IPC and we are safe, we are protected. So this is good act as far as our MTP services are concerned. And in that very this act, one good provision is in section 5. So as far as section 5 is concerned, if you terminate pregnancy to save life of patient, if to terminate pregnancy immediate necessary to save life of patient, you can terminate pregnancy at any given gestational age and even at unregistered place also. But burden of proof is on your shoulder to prove. Of course, we are given protection in section 5 of MTP Act, but we should be in a position to justify our decision. And if we can justify in court of law, we are always safe. So these are some amendments and its benefits to the patient and to practicing doctors.
Thank you, sir.
Thank you.
Dr. Sukriti Sharma Bansal, Secretary of Jalandhar Society. I cannot see if she is here. There are a few iPhones, so I don't know if she's here. Ma'am,
Is
are
she
you
here
here?
or anybody from Jalandhar may take, no issue.
You want it, sir?
Yes.
Sukriti is not there. Should I take it, Dr. Asha?
Oh, yes. Oh, yes.
Okay, sir. Sir, what are the violations of the Act commonly which are seen in court? You are dealing with them so frequently. And are the medical abortions also covered under this Act? And what are the forms to be filled and the provisions of personal privacy of the lady under the Act?
So as far as violation of Act is concerned, commonly allegation are person is not qualified or place is not approved or all the formality related to records, that is preservation or maintenance of record, are not fulfilled and abortion is not carried out in a safe environment. So abortion is unsafe. So these are common areas or common allegation and proceedings are happens in court of law. Either this registration is suspended, case may be filed also before honorable court. As far as your second question is concerned, medical abortion is one of the accepted method of termination of pregnancy. So all the provision of MTP Act will be applied. So you will have to go with all the forms and all the formality related to MTP Act. As far as forms are concerned, there are so many forms related to this MTP Act. From we may start like this. Form A. So at the time of registration, one has to apply in prescribed form, that is Form A. If your center is registered, then you are given certificate of registration, that is Form B. Consent is to be taken as far as MTP patients are concerned, and that is prescribed form, that is Form C. You have to take consent in Form C only. But in Form C, it is merely mentioned that I give my permission to Dr. So-and-so to terminate my pregnancy. So it is simple consent in Form C, it is prescribed form, but it is not informed consent. So I would advise to go with two consent. One consent in Form C, which is very much mandatory under MTP Act, and one uniform consent. So in uniform consent, we have to explain everything in detail related to our services, if it is medical method or if it is a surgical method. And you have not to worry for that. You have to simply visit Foxy website, and on Foxy website with Foxy uniform consent, there are 30 different consent available. We three medical legal experts, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared 30 different consent. Say, for example, consent for cesarean section, consent for hysterectomy, that is for abdominal or vaginal or endoscopy, consent for termination of pregnancy, medical method, surgical method. That way, all the consents are available on FOXI website, you can download and you can utilize in your day-to-day practice. So this is Form C. One form is Form D. So this is opinion from medical board. So medical board will have to opine in that very Form D. Some other forms are concerned. Then Form E, when pregnancy is more than 20 weeks and less than 24 weeks, 2 registered medical practitioner will opine. So, and for that there is a prescribed form, and that is Form E. So you will have to opine in Form E if pregnancy is more than 20 weeks and less than 24 weeks. As far as some other forms are concerned, Form 1. Form 1 is opinion of 1 registered medical practitioner up to 20 weeks of pregnancy. Because with this amendment, only 1 registered medical practitioner can opine, and pregnancy up to 20 weeks can be terminated. So that opinion is to be formed in Form 1. It is again one more prescribed form. Form 2. Form 2 is monthly reporting. So at the end of month, we have to report to appropriate authority in that very prescribed form, that is Form 2. But in Form 2, we have to give only statistic. No personal identity of any patient is to be revealed in Form 2. Because in Form 2, it is very prescribed form. Say, for example, total number of cases of MTP in last month. Say, for example, in month of February, say, if you mention 20. How much up to 8 weeks? Say, for example, 4. How much up to 12 weeks? How much up to 20 weeks? How much from 20 to 24 weeks? How much more than 24 weeks? That way, all columns are there, and you have to simply go with statistic. One more area is in that very Form 2. How much of those patients, Hindu, Christian, Muslims, that way also there are some columns. And one more column is indication. For which indication you have terminated pregnancy. Say, for example, failure of contraception. Out of 20, how much termination were done for that indication? You have to mention figure. Say, for example, mental trauma to the patient if pregnancy is continued, or physical trauma to the patient if it is continued, or if it is due to rape, pregnancy occurred due to rape, or if fetal congenital anomaly. So whichever the indications were, you have to simply mention statistic in Form 2. One more form is Form 3. That is, we can call it MTP register or admission register. And it is again prescribed register. So in that very register, all the details of patient is to be mentioned. Name, age, address, parity, by which method you have terminated pregnancy, who has opined to terminate pregnancy, 1 doctor, 2 doctors, whichever the as per the case may be. And one more column added with this amendment, which method of contraception was adopted by patient after termination of pregnancy, and by which method pregnancy was terminated. So this is Form 3. So these are some different forms as far as MTP Act is concerned. All the forms are available on website. You have to simply write MTP Act 1971 and you will get all those forms. What are the forms to be filled and provisions personal privacy? So as far as personal privacy is concerned, so I mentioned prior also, we are under obligation to keep confidentiality of patient who has undergone MTP. So once her name is entered in MTP registered, that is Form 3, all other correspondence will be done with number given to that very patient in MTP register. Say, for example, you have given number 5/2024. And then after all the correspondence, that means if you are entering details in OT register, then it will go with number only, 5/2024. So no name of patient is to be written in that very OT register. Or in any other correspondence, you will go with number only. So as far as privacy part is concerned, and I mentioned prior also, if at all it is a breach of privacy, breach of confidentiality, then there is a provision of 1 year of imprisonment. So we should be serious to maintain privacy and confidentiality of the patient. Yes, next.
Thank you, sir.
Thank you, sir. That was a really very long answer. Next, we have Dr. Nishi Garg, New Society, Katkapura, and
Sorry.
she loves making friends, traveling, giving speeches here. So, welcome, Dr. Nishi. Over to you.
Good evening, sir. And
Welcome.
wish you best of luck, sir. And we are with you.
Thank you. Thank you.
So with that, I would like to ask, who can be shown the documents of the lady after we have done her MTP, and who is the authority on whose orders papers are to be shown? The next part is MTP form is submitted online to district authority.
Dr. Nishi, you can take one by one.
Okay.
Yes, one by one.
Take
We
one
will
by
go.
one.
Okay.
So, as far as this Kotkapura Society is concerned, I had privilege to be present at the time of installation of new team when this Kotkapura Society was formed. And Nisi is good host. She extended me a warm welcome and good hospitality. Thank you, Nisi, for the same. So your question, who can be shown document? As far as confidentiality is concerned, there are provisions, and in MTP Act it is mentioned that MTP register, where all the information of patient is there, can be opened in two cases, condition. One, if patient is working woman and if she wants certificate to grant leave, then we have to open that certificate and we have to issue certificate to the patient. But we are issuing that certificate to the patient. If patient is willing to give that certificate to her employer, that is up to her. We are not giving information to employer directly. But at the same time, when we issue this type of certificate, we should write to employer also, this is confidential information related to the patient, and you are also requested to keep it confidential. So this is one provision. Second provision is under authority of law. Person who is authorized by law can inspect all these documents. So CDMO, that is Chief District Medical Officer, is appropriate authority as far as MTP services are concerned, and he can inspect this register. One more area, if at all there is a litigation, then investigating officer may inspect that register. But in this situation, we can ask in writing, because there should be litigation or FIR, because many a time any unknown person will introduce himself or herself that I am investigating officer for that very case. And if we give information, it will be big trouble in court of law. So we should have a copy of that very FIR or complaint file in that very particular case. And then only we can give a record related to that very patient only and not other patients. So he cannot inspect register total. That part only we can show him or her. And at the same time, whichever information we give to that investigating officer, it should be given with acknowledgement. And only Xerox copy is to be given. Original should always be with us. Yes, next.
The second question is that MTP form is submitted online to the district authority. Then what about the privacy?
I mentioned prior also, when we submit record to district authority online or physical, it is in form 2. And in form 2, nowhere any personal identity of any patient is revealed. We go with only statistics. Total number of pregnancy terminated up to 8 weeks, up to 12 weeks, up to 20 weeks, which were the indication, 5, 6, 7, whichever the number may be. So no personal identity is revealed in that very form, even if it is online or it is on physical form.
So third one, sir, with OTC availability of MTP pills, like people are coming after taking these pills to us. So where does the reporting on MTP stand in these cases?
So as far as OTC availability is concerned, it is totally illegal. But patient should file a complaint against that very pharmacy or any unauthorized person who sells this pills, MTP pills. If at all, if any complications occurs with this type of pill and patient comes to you, say for with heavy bleeding or patient is in a shock, of course you have to treat patient. But in this situation, you can inform police. If patient or patient party is willing, if they are not willing, then we have not to inform. And in that point of time when we inform, we will give history that patient gave history of taking MTP pill over the counter. So that way only we can pursue.
And what is the role of gynec when such a lady comes with retained products?
Yes. So when she comes with retained product, it is a complication of pregnancy or complication of procedure. So we have to deal with that very patient accordingly. Here, MTP Act doesn't come into picture. So no form C, no form 1E, whichever the case may be. You have to treat that very patient as we treat any other patient. But it should be well mentioned that if at all it is a history of a medical pill or termination of pregnancy at another place, say for example, she might have gone with surgical termination at any other place, and with retained product she may come to you also. So as far as history is concerned, whichever history patient gives, we have to mention in our history.
Thank you, sir. Thank you.
Welcome.
Thank you so much, sir.
Yes.
Thank you, Dr. Nidhi. Next, we have Dr. Madhu Goyal, ma'am. So she is the secretary of Koktapura. And sir, एक बार देखिए. So she runs her own Madhu Nursing Home and IVF Center. Over to you, Dr. Madhu.
Good evening, everyone. Good
अभी निकल हुआ के तो पहले लगवा ले.
डॉक्टर मधु अपना प्लीज वीडियो ऑन करिए, आपकी आवाज आ नहीं रही है.
There is some connectivity issue, I think.
Yeah. डॉक्टर निशी आप ले लेंगे क्या?
I think she's not able to connect.
Yeah, I have started video.
Madhu, your network is problem. Network problem is
there. Madhu has.
You are hearing me audible?
Yeah, now it's okay, Madhu. Now it's okay.
Yeah, I'm
not with two devices.
Am
Madhu?
I audible?
One. Yes, now you
Yeah,
are
I
audible.
have. Okay. Thank you, Dr. Patel, sir. And
Yes.
thank you, Asha ma'am, for such a informative and good lecture. And it's really informative. And my question is, a lethal deformity detected in anomaly scan, can MTP be done?
Yes. As far as lethal deformity of fetus is concerned, up to 20 weeks of pregnancy with opinion of one person we can terminate. More than 20, less than 24 weeks with opinion of two registered medical practitioners we can terminate. And more than 24 weeks with opinion of medical board we can terminate pregnancy.
And next question is non-lethal anomaly detected at 27 weeks. Can MTP be done? Under which provision and what is the legal procedure involved?
So as far as non-lethal anomaly is concerned, and if pregnancy is more than 24 weeks, even medical board cannot opine, because medical board is conferred with power to opine in pregnancy more than 24 weeks in case of lethal fetal congenital anomaly, or what exactly used is fetal congenital anomaly incompatible with life of fetus. So other than all those cases, even medical board has no power to opine. So in this situation, one will have to go to Honorable High Court seeking writ petition, seeking permission of termination of pregnancy. But if it is immediate danger to life of patient, even if non-lethal anomaly is detected, and if it is lethal, immediate danger to the life of patient, then pregnancy can be terminated. under Section 5 of MTP Act. But in other cases, as far as non-lethal anomalies are concerned, you have to go to Honorable High Court.
Thank you, sir. Thank you.
Yes.
Thank you, sir. Dr. Geetanjali is there. She is the president of Ludhiana Society and she's secretary of SFM Ludhiana. She likes cycling and traveling. Not here at present. I would request Dr. Ruchi, would you please take this question, ma'am?
Yes, sure, ma'am. Sir, who gives consent in a major lady and is the partner's consent required?
So when patient is adult, when patient is mentally sound, only and only patient can give consent for termination of pregnancy. And no consent of partner is required.
And is a separate informed consent along with Form C required?
Yes, I mentioned prior also, it is available on FOXI website. You have to simply download FOXI Uniform Consent, and in 30 different consent we have prepared. One consent is for termination of pregnancy by medical method. One more consent is termination of pregnancy by surgical method. You can download and you can utilize in your day-to-day practice.
Thank you, sir. This was a great learning.
Thank you, sir. Sir, thank you, Dr. Ruchi. Now we have Dr. Gidney Gupta, who's the secretary of Ludhiana Society, but she has not been able to be here.
No, I think
She
I'm
joined. Welcome, Dr. Gidney.
Yes, Guinea is there.
Yes.
Asha, Guinea is there. Yes, Guinea.
Over to you, Dr. Gidney. She
Welcome,
likes
Guinea.
like cooking and exercise. Over to you, Dr. Gidney.
By Dr. Sudh. And as usual, Dr. MC Patel's presentations and your help. Personally, to me, I must take a second to thank you. I have consulted him often and he has always been helpful. So, sir, as we conclude the seminar, one thing I wanted to ask pertaining to Dr. Geetanjali's question, if the patient is not married and later we do the MTP on her consent, she is 25, and later on she files a complaint of rape against the person, then what? How will we be protected?
This is usual scenario, and it happened in one of the cases in Gujarat also. I was defending that VRE gynecologist. So it is very clear when patient is major, irrespective of her marital status, she can give consent for termination of pregnancy. So at that very point of time, she is very clear in her mind. She had no complaint against that very boy also at that point of time when we terminated pregnancy. But to be on safer side, we always advise to our friends, delegates, that in writing, if patient gives in her own writing, it is always better. Otherwise, we can write and patient can sign. It is a result of consensual sex. I have no complaint against anybody and I do not want to inform police. These 3 lines by patient or a signature of patient at the end of these 3 lines will save you in court of law in this type of situation. Because if at all patient lodges complaint against that very boy of rape, you will not be held into consideration or in trouble. Because at that point of time, patient was very clear. She had no complaint against anybody and she had given valid consent without any force. So this type of writing we should have.
Thank you, sir. Wonderful. That is wonderful because of the changing societal norms. We are facing this every day. So in an unmarried adult woman,
yes, you are right.
That takes the consent of consensual act.
Yes.
Okay.
Yes.
Sir, my question from in the panel is, any interesting cases for learning for us on the mistakes we need to avoid?
So I would like to mention one very interesting case which happened in city of Ahmedabad only. Our senior gynecologist in 2003, he did termination of pregnancy. His hospital was registered, he was qualified, and a termination of pregnancy was done. In 2004, that is 1 year after that termination, there was quarrel in the family. And patient filed a complaint against in-laws that it was forceful abortion without my consent against my will, and case was filed. Doctor was called in court of law for an expert witness. So court asked from doctor, can you produce consent given by patient, that is form C, and opinion formed by you, that is form 1. And it was very casual answer on part of doctor that it was OPD patient, and we do not preserve any record as far as OPD part is concerned, and we give OPD paper to the patient. And court ordered to arrest doctor from court only, and doctor was arrested. After 3 days, there was compromise in that very case was withdrawn, and then after only doctor was out of bar. So we should be very careful as far as MTP services are concerned. Consent should be taken in form C. If you have not taken consent in form C, it is all likely that you may be tried under section 313 of Indian Penal Code, that is MTP without consent. And there is a provision of 10 years of imprisonment, and one cannot afford that. And that is why consent is to be taken in form C. Of course, one consent in informed consent we have to take, but that cannot replace consent to be taken in form C. So consent in form C is very much required.
Sir, what is your final minimum recommendation to avoid litigation in MTP?
Yes, as far as recommendations are concerned, center should be registered first, person should be qualified, and termination of pregnancy should be in accordance with provision of MTP Act 1971. So consent in form C, opinion in form 1 or in form E, whichever the case may be, or opinion from medical board, and all the records related to MTP Act, we have to maintain and we have to preserve for 5 years. Yes, next.
Thank you, sir.
Sir, next is Dr. Sarita Agarwal, ma'am, who's the president of Patiala Society. After 40 years, she started painting, sir, in Corona.
Very good.
Have a look. So, over to you, Sarita, ma'am.
Yeah, thank you, Dr. Asha, and thank you, Dr. Patel, for being a savior there always to every Foxian. Thank you. My questions are pertaining to MTP greater than 24 weeks. Like in that case, if the baby is born alive, that is after the viability.
Yes, I got your
we
question.
are actually in
Yes.
passive euthanasia, right? In that case, if the baby is born alive, who should be given the custody of the baby? My first
So
question.
this is very tricky situation, because when this termination of pregnancy is allowed more than 24 weeks, many a times fetus may come alive. So at the time of taking consent, it should be clarified to the patient and patient party, if at all you have involved any other relative in that very case, that custody of baby will have to be taken by patient only. Because many times what happens in this type of situation, when termination is over, fetus may alive and patient is not ready to take custody of fetus. So in this situation, one more very important question is, can we ship that very baby in NICU? Of course we can ship. In government hospital, there is no problem. Baby can be shifted in NICU. But as far as private setups are concerned, if at all we ship baby in NICU, then who will bear cost of that very NICU expense?
Yeah.
So here comes role of police. So you can inform police in this type of situation that at the time of giving consent, they had given consent to take custody of baby, I mean fetus, and now they are not ready to take custody of fetus. And one more area, here comes role of IMA, role of FOXI, that in this type of situation, there should be clear-cut guideline on part of government, because these are some gray area. There is no clarification in MTP Act also. If fetus comes alive, then what to do? So in this situation, all this IMA, FOXI can approach government to clarify this type of gray area. And in a lighter way, I tell, you will have to vote for me. Once I become president of FOXI, all this gray area taken into consideration to government of India. Thank you.
Right. I just wanted to ask another question.
Yes.
Like when we can have a prior feticide. in certain cases with intracardiac KCL. What I read through is like you have to approach the court for it. And what is the minimum time they have to give the verdict? Is it 7 days or beyond 7 days for getting a permission for intracardiac KCL? If we are having a planned feticide.
No. As far as opinion from medical body is concerned, then medical body is under opinion to opine within 3 days. They are under obligation as per Act.
Okay, you needn't apply.
No, but if there is an indication for termination of pregnancy, when center is registered, you are qualified, you can very well go with termination of pregnancy. In each and every case, no permission from medical body is required. But as far as feticide part is concerned, say for example, opinion from medical board is given that pregnancy can be terminated, and pregnancy is of 28 weeks of pregnancy. So it is all likely that baby may come alive. So this question was raised: can prior feticide be considered? Because in multiple pregnancy, when there is a reduction in pregnancy, then we go with KCL or so intracardiac, and heart is stopped, and rest of the pregnancy is continued. So in this situation, before termination of pregnancy, not to have live fetus, can we go for feticide? Again, this is gray area in MTP Act. But if with prior consent of patient, if we consider, then it cannot be challenged in court of law.
Okay.
Yes,
right.
next.
Thank you, sir. That is very great.
Yes.
Great information.
Thank you, sir. Next, we have Dr. Lajja Goel, ma'am, who's the professor and HOD at AIIMS Bhatinda. I could not see her here.
But anybody can take.
I'm there, ma'am.
Yes, ma'am. Welcome.
Oh, yes. Welcome, madam. Welcome.
Thank you, sir. And thank you, Asha ma'am, for giving me this opportunity. My question is that 26-year-old, third gravida, para 2, living to having 22 weeks pregnancy for MTP, with reason given is failure of contraception. Will you or can you do the MTP for such case?
No, because here pregnancy is 22 weeks. And indication of failure of contraception to terminate pregnancy is available up to 20 weeks of pregnancy. So if pregnancy is more than 20 weeks, this indication is not available.
Sir, one more question. That new medical colleges are coming up every now and then. So if there is a government sector which a medical college is started, do we have to separately register for doing MTP in government setup also, which is a medical college? Automatically such type of cases will become.
So in MTP Act, it is very specifically mentioned places where MTP can be done or can be offered. In that very section, it is written government hospital or any hospital run by government or aided by government, or any center which is registered by government or district level committee. So as far as government hospital or medical college hospital is concerned, these are the places they are automatically eligible to terminate pregnancy. But as far as all this formality, Form C, Form 1, in medical college also, you have to object. And reporting, monthly reporting also.
Thank you, sir. Sir,
Thank
we'll
you,
have
sir.
to speed it up a bit because we are running quite late.
Yes.
So, sir, we have Dr. Venus Bansal with us. She has so many affiliations, such a dear friend. And she has a dog exactly like my buddy. And she's a social worker, works for females in slums, jails who are mentally challenged, post-sexual assault, and many more. Welcome, Dr. Venus. We are all with you. You're muted. You need to unmute yourself.
Am I audible?
Yes.
Yes.
Okay. Yeah, first of all, I'm so happy to be with Sir and Asha ma'am and all my friends on this platform today. MC Patel sir, आप सबके लिए ही you have been so helpful always that I think thanks is a very small word for that. My question for the audience from you is like 19-year-old unmarried girl was brought to hospital in shock by A&M practicing in periphery, who did her criminal abortion and her at her clinic at 3 months of pregnancy, and she is accompanied by her parents now. She's in shock, momentum is hanging out. What to be done? That is the first thing. And resuscitation and all. And after that, what is the legal proceeding that we have to do? Definitely,
as
there are two parts of it. One is
yes,
the medical part and other is the legal part.
yes. Naturally, we have to manage that very situation accordingly as per standard medical norms. Because in one of the famous case of Parmanand Katara, court has very specifically mentioned, first you treat the patient, all the legal formalities afterwards. As far as legal part is concerned, if patient and patient party are not willing to lodge complaint against that very A&M, that you need not to inform police. But if they are interested, then you are under obligation to inform police. But I have observation, I have in so many cases, if this type of cases are brought to medical college hospital, they have one police officer present and with 0 number cases filed. And then all this inquiry goes with that very A&M, etc. But if at all there is a complaint, then that very A&M will be in a big trouble because she is not qualified person. She has done MTP at unregistered place. So she will be in a great trouble. And if at all case is decided or concluded, then there is a provision of imprisonment of 1 to 7 years of imprisonment. So it will be very difficult for her also. But as far as our party is concerned, we have to treat patient, and if patient party is interested, then we have to inform police.
So it does, sir, there is any role of that just we send police information, PI, and FIR is as per on their choices?
No, we are informer, we are not complainant. We have to simply inform police that this type of case is brought to me and a patient is in a bad condition and I am dealing with a treatment. So this is just to inform you. That way you have to inform. What to do on part of police, that is up to them.
Right, sir.
So next we have Dr. Supreet Virk. She is senior consultant at Jalandhar. I could not see her joined here. Her hobbies are cooking and baking and social work. Requesting anyone from Jalandhar would take this, please.
Should I take it if there's nobody?
Yes, please proceed, ma'am.
Okay. A 22-year-old unmarried girl comes to the doctor with her boyfriend, very common these days, and asking to have termination of a 3.5-month pregnancy. What is to be done, sir?
So here she is 22 years. So she is major. She can give consent for termination of pregnancy. So there is no issue. But it is always better to confirm her age because many times patient gives history of age more than 18 years and many times she might be minor. So in this type of situation, always ask for Aadhaar card or any ID proof to confirm her age. And you can terminate pregnancy with her own signature only, no issue. But here pregnancy 3 months and 3 and 1.5 months. So in this situation, up to 20 weeks of pregnancy, with opinion of one registered medical practitioner, one can terminate pregnancy. There is no problem. But just we discussed prior also, she is unmarried. In future, there could be some dispute with that very boy. So it is always better to write, just I mentioned about, it is a result of consensual sex. I have no complaint against anybody. I do not want to inform police. And if you go like this, then you are safe.
Thank you, sir.
Yes.
Thank you, sir. Next, we have Dr. Tapasya Dhar, ma'am. She's a professor at CMC Ludhiana and she paints tote bags. She loves cooking as well. So these are the sample of the tote bag she has painted.
Good.
Mouth-watering food. Over to you, Tapasya ma'am.
Thank you so much, Dr. MC Patel, sir, and Dr. Asha, ma'am, for inviting me to be a part of this session. Sir, my question to you is, a 29-year-old patient conceived with ART has triplets. She is advised fetal reduction. Should the center be registered for MTP, and does it come under the MTP Act? And which forms are to be filled?
So as far as fetal reduction is concerned, it doesn't come in purview of MTP Act because here there is no termination of pregnancy. Pregnancy is still continued. So as far as MTP Act is concerned, it is related to termination of pregnancy. So to reduce triplet to twins or twins to singleton pregnancy, it is not termination of pregnancy. So no form is to be filled. But we have to take care, or we have to go with informed consent as far as fetal reduction part is concerned, with all its probable complication, etc., not to end up into any other litigation. As far as MTP Act is concerned, we have not to worry because we have not to go for Form C, Form 1, nothing, because it is not termination of pregnancy.
Thank you, sir.
Yes.
Thank you, sir.
Next.
Now we have reached the end. We have Dr. Bhavna Sachdev ma'am, who's the Senior Vice President of Ludhiana Society. Very, very active, dancing, singing, but I didn't have time to cut her videos. So this is Dr. Bhavna Sachdev ma'am. Over to you, ma'am. You're muted.
Yes, ma'am. Thank you so much, sir. And thank you so much, ma'am, for giving me an opportunity to be a part of the webinar today. And thank you so much, MC Patel, sir, for being helpful to us as and when required. And all the best to you, sir. So my question for today is, sir, we have a patient coming to us. She has 6 weeks of pregnancy. And the center is registered, the person is qualified, but the patient comes alone. And she asks for a medical abortion. Are we allowed to do it? And if she asks for a surgical abortion, are we still allowed to do it? The center is registered and the person.
If she is major, then we can very well go with medical termination of pregnancy, no issue. But as far as surgical termination of pregnancy is concerned, of course, if she is major, she can give consent. But in one of the cases, it was happened that termination of pregnancy was carried out by surgical method, and there was perforation, uterine perforation, and there was profuse bleeding, blood transfusion was required, laparotomy was required. And in this situation, then relative were informed, relative came, patient was well taken in OT, and patient was saved. But case was filed by relative. Why you didn't inform us before going for surgical termination? Legally, it cannot be challenged because she is major, she can give consent. But as far as this type of social problems are concerned, if we are going to terminate pregnancy by surgical method, somebody should be present outside OT. Of course, in form, we have to take signature of patient only. No signature of any relative is required legally. But if somebody is there waiting outside operation theater, and if at all some complications happens, then we can manage situation accordingly with that very relative or person waiting outside. So if patient has come alone and for termination of pregnancy, to go with surgical method is little risky. Of course, it doesn't happen in each and every case, but we should be careful.
So one more thing I would like to ask here is, time and again we say that the center should be registered and the person qualified. So can a qualified person who has an OPD setup like many of us have, so if we give medical abortion, so if we are affiliated to one center, so can we take the person to another center if the patient is medical condition?
Yes. So if you are running only OPD or consulting room, so are you allowed to advise medical termination of pregnancy? Yes. But you should have access to any registered center where you can tackle all the complications related to your treatment offer. Say, for example, if you have given a simple medical termination, MTP pill, and patient ended into incomplete abortion, and if emergency DN is required, then access to that very hospital is available and you can deal with that very situation there. And this type of board should be there in your waiting room, that your hospital has access to this hospital. And if at all any complications happens, then complication may be taken care at that very hospital.
And
If you have this type of board, you are allowed to prescribe medical termination of pregnancy by medical method, even if you are running only OPD or this consulting room. But at the same time, report related to that very patient to whom you will send all the reports to that center whom you have access, because you cannot directly send report to district appropriate authority.
True, sir.
Because your center is not registered that way. So you will send report to that center, and compiling his report and your report, he or she will send report to appropriate authority at the end of month.
And sir, what is the onus on the center? Can the center refuse the patient if they have given you a certificate? But this is a general question. Like if we refer the patient to the hospital and we have to take the patient to another hospital, that hospital is not well equipped for the condition. Like this patient came in shock.
In this situation, we can advise patient all the options. That these are the options you can opt. But ultimate decision where patient wants to go for further treatment, that is up to her only. So if she is willing to go to some particular place, then she can go there. No issue.
And sir, very, very this thing, but like if we have already,
Yes, carry on.
so if we have already given a medical abortion, so do we after that can we can the patient be taken to a hospital which is not recognized for MTP, since now it is not an MTP?
Yes, as far as to deal with any complication, you can, no issue. Because there is no formality of Form C, Form 1, Form E, whichever.
That has already been filled.
So, because this is already filled and this is complication. So complication can be taken care at any place, even at unregistered place also.
But if it is a failure of MTP, sir, and the embryo is alive, then it would become a termination.
Then it is
So
an
if it is failure of this, say for example, MTP is given, or in very early pregnancy, surgical intervention is given and still pregnancy is continued. And if that very pregnancy is terminated, then that very pregnancy can only be terminated at a registered place and by qualified person.
Thank you so much, sir.
Can I ask one question, sir?
We have justified all the questions and all the situations, and hopefully it could be beneficial to all the delegates who have joined this webinar. And again, at the end, my humble appeal to endorse my candidature for post of President Foxy. In month of May, all the society will receive email from Foxy to nominate my candidature. So we'll have to nominate my candidature in month of May, and in month of August from 1st to 10th, there will be voting. So you all will have to vote for me. And the same way, Dr. Asha Jain is also contesting for post of Chairperson, Food, Drugs and Medico-Surgical Equipment Committee, Foxy. And her election would be on 16th of August to 25th of August. But in that election, only society votes. So society will have to nominate her also in month of May. And at the time of election, society will have to vote. So president or secretary, whomsoever gets the ballot, will have to vote. So it is my appeal to endorse the candidature of Asha Jain also and to vote for her also.
Thank
Thank
you, sir.
you very
Thanks
much,
a lot.
Dr. Thank you, sir. Thank you.
Thank
All the
you.
best.
Thank you, ma'am.
Thank you.
So thank you, sir. You
Thank
gave
you.
very clear answers, but we are really still on time. I thank everyone who's present here. Our senior Sushma Chawla ma'am is still here. Neelam ma'am is still here. And even Iqbal sir is there. So, sir, if you would like to say a few words,
Yes, sir.
you are most welcome.
Any expert comment from Iqbal sir and Sushma madam?
Yes, what I will say is excellent. And the things have been very detailed. And for Dr. MC Patel, we wish, not only we all wish you all the best. And we are sure you're going to win. And only one word is for you, super. That's good.
Thank you, sir. Thank you.
Thank you
Yes,
very
Sushma madam.
much. I thoroughly enjoyed the whole session. I had to go somewhere, but I've cancelled it. But I think from the medical legal point of view, as you said, the file work, the pulse, blood pressure, for the anesthesia, consent, everything is required because it can be first, it can be second trimester, it can be 24 weeks. So I think from the medical legal point and from the social aspects also, many times we have seen every other day the doors and the pane, they are broken up because even the neighbors, they come and fight. So I think we have to protect ourselves as far as the social surroundings are also concerned. Otherwise, the form and the confidentiality should be there. But a file with everything, with our all nursing care must also be there. Thank you very much.
Thank you. Thank you, madam.
Thank you.
So with this, thanks to all the delegates, President, Secretary of Joining Society, and our speaker, panelists, the chairpersons, and all honorable guests. Thank you all.
That is my job to say the official vote of thanks.
Yes.
Done, ma'am, done. Thank you so much, everyone.
Iqbal sir, Sushma ma'am, Saroj Agrawal ma'am, she was also present here almost till the very end. Thank you, Ruchi ma'am, Manjeet sir, Amita Sharma ma'am, Sunita Goyal ma'am. I also thank Dr. Monica Gupta, Dr. Jagjit Singh, Dr. Surjit Kaur, Dr. Sukirti Bansal, Dr. Nishigar, Dr. Madhu Goyal, Dr. Geetanjali, Dr. Ghinni, Dr. Sarita Agarwal, Dr. Lajja ma'am, Dr. Venus, Dr. Supreet Vir, Dr. Tapasya, and Dr. Bhavna Sachdev for sparing their valuable evening here. I also thank Corona Remedies and Nilesh in particular for making this program possible. No less, the audience is what makes everything worthwhile. So I thank the entire audience who has listened to us and spared a precious evening, 2.5 hours with us. Thanks a lot. Thank you again. We meet next week, Tuesday, same time with a different topic. So next Tuesday, 6 p.m., Happy Masterclass 185. Welcome. Till then, namaskar, shubhratri, good night.
Thank you. Yes, Nilesh, we can conclude.
Thank you so much. Now we have successfully completed the 184th edition of Happy Learning Masterclass webinar series with Dr. MC Patel sir. And we would like to contribute again more and more such a wonderful webinar with you, sir. So with this, I'm again thanking all the
I think MC Patel sir deserve 3 cheers.
Thank you, Vinay.
So thank you so much, and I'm ending the session now.